Hello and welcome to another brand new episode of the MEN1 Mosaic podcast. Today, my guest is Dr. Ruth Casey, who has agreed to come on and speak to us in her sort of capacity as a consultant and research fellow. I will let her introduce herself so that I don't get it wrong. Hi, Ruth. It's lovely to have you on here. Thank you so much for joining. Can you please give us a little bit of an introduction into who you are and how you've got to where you are now in terms of your capacity to work with MEN1?
Okay, so yeah, I'm Ruth Casey. I'm a consultant endocrinologist in Addenbrooke's in Cambridge. So I'm the neuroendocrine tumour lead and the endocrine genetics lead in Cambridge University Hospital. And in our clinic, we see patients with hereditary endocrine conditions, including MEN1, MEN2, and other hereditary endocrine conditions. So I've been consultant here for the last 5 years. I also hold an academic contract, so I do some mostly clinical and translational research on the topic of endocrine cancer and hereditary endocrine disease. And I got here, I came from Ireland. Obviously, most people will cop that from my accent. But so I initially came to Cambridge about almost 10 years ago now to do a PhD. And that PhD was in another gene called succinate dehydrogenase, which also predisposes to hereditary endocrine syndrome. And really, I came here to gain experience in rare endocrine disease and rare hereditary endocrine conditions. And I never went back to Ireland. I stayed. And so, yeah, I'm really lucky and very fortunate to be able to practice in a subspecialist area that I've always been very interested in, both clinically and academically. So, yeah.
That's fantastic to hear, and thank you so much for the introduction. I wanted to ask you actually mostly about your capacity as a consultant, so working with patients. Obviously, the community, the listeners of this podcast are patients themselves, and often wanting to know how it is that they can improve strengthen their relationships with their healthcare team, what it is they can do to keep things running as smoothly as possible. And I wondered, what is it, in your capacity as a healthcare provider, what is it in your experience that helps to make things smooth and effective? And what is it that patients can do to kind of make, I guess, an active contribution towards their healthcare? So not so much sitting back passively on the sidelines. What is it that means that they can get involved and feel as though they're being listened to?
Yeah, so I think it's a really important question. I think it's super important because lots of patients probably have multiple teams that are looking after them. Certainly in Cambridge, because we offer specialist support or tertiary referral support to the wider region of East Anglia. So we will often have patients that we see maybe once a year, but then they also see their local endocrinologist maybe in their local hospital. So what common theme for patients is that they can often be frustrated by the fact that our communication systems aren't all linked up. And also sometimes I think it can be a bit disorientating for them in terms of who's in charge and who's running what aspect of their care. So, I mean, I think there's no one answer, one easy answer to your question, but I think what we try to do and what I try to do when I see a patient for the first time in clinic is obviously to try and impart as much knowledge as possible. So give the patient as much knowledge as possible about their condition and signpost them to useful resources like, the MEN website, for example, which contains really helpful information for patients. And I think it's really important to gauge in the beginning. Every patient is different. Some patient will come to clinic and be able to absorb lots of information. Other patients will come and be really overwhelmed, and you can tell that quite soon into the consultation. So it might be that you have to see them a second time to be able to give them all that information. So I tried to outline from the beginning in the first 2 consultations what exactly their screening is going to entail, what it means, what their condition means, what it's going to mean to them. Patients will often ask what it's going to mean for their families, especially if they're the first person in the family to be diagnosed. And even for patients who aren't the first person in the family to be diagnosed, they'll have other family members that they will have seen go through, screening and potentially be diagnosed with, various manifestations of MEN1, and they will have their own anxieties from their own experiences. So I think the first 2 consultations is really just working through, what to expect for the patient, what the screening will involve, and then ultimately to give the patient as much information as possible, so that I suppose so that they have the power to kind of lead their own care in a way, um, you know, and also so that they know what questions to ask, um, and when to, we try to say to them as well in terms of when to call us up, when they should expect scans, what to do if their scans are delayed, how often they need the blood tests, so that the patients really become kind of their own advocate in a way as well, which I think is really important, especially when there's multiple teams involved in their care. And especially when some of these patients will be very young and maybe moving away for university and all of those things. So I think, yeah, the first 2 appointments, I think we try and impart as much knowledge as possible. And I think the most helpful thing a patient can do is really easier said than done, but really try to engage as much as they can in that process from the very beginning.
You mentioned the need to sort of gauge, I guess, where a patient's at in terms of how much knowledge they can necessarily understand or is, necessary for them, and it can all be very overwhelming. I have spoken to a number of different people within the patient and professional community, actually, in terms of MEN1 and this idea, well, not the idea because it's actually in existence, the patient portal, which obviously we can all access and we can see our results come in literally probably at the same time as they come to you. Um, I was wondering, in your experience, is this necessarily a very good thing for patients to have access to? And I ask this only because I know from my experience and from speaking to other patients, it can be incredibly overwhelming receiving results and having absolutely no context in which to set them and no idea what they mean. And ultimately, I suppose for someone who is on the more anxious side, maybe that means they freak out, they panic, they try and jump on the phone or an email or whatever. Do you think it is necessarily a very good thing for us to have access to?
I'm smiling because I have quite a fixed opinion on this, but so I think it's really useful for patients to be able to access their chart and see when their appointments are, to see, to have that ability to change appointments or to request a change of appointment, be that for scans or for clinic appointments, especially for patients with MEN1 who will frequently have to come up for multiple tests over the course of a year, etc. And I think it's really important for patients to be able to see their drugs, their medications, and to be able to update those, because studies have shown that that's one of the things that's probably less well recorded from a healthcare professional point of view in terms of updating drug lists. So I think it's really a good idea for patients to be able to access that and their appointment scheduling. I don't think it's a good idea for patients to have first glance at their results for lots of different reasons, including very straightforward practical reasons, including that. So, for example, sometimes reports will go online for a scan, and it will be a provisional report, and it may not have been reviewed by a consultant, and that result may subsequently be updated. And we as healthcare professionals will usually not write to a patient with a provisional report. We will almost always wait for a definitive report, and sometimes we won't even write to the patient with a definitive report. We'll have it reviewed at an MDT before we even write to the patient. But at the moment, the patient will have access to that very preliminary report. And they'll also have access to blood results that don't always come with a reference range. So a perfect example of that is fasting gut hormones, which patients with MEN1 will frequently have. There's not really a reference range for those. There is sometimes, depending on the assay, but again, lots of things can interfere with those results, like very practical things, including if the patient hadn't been fasting for 12 hours, or if the patient has new medications, and they can cause significant alterations in the results. And seeing that result come up as red in bold sometimes with an exclamation mark, and that's sometimes how those results appear on the portal for patients. I mean, that can be really and understandably anxiety provoking for patients, especially if they don't have the context or they can't interpret the results. And it may be another couple of days. For example, if a result comes through on a Friday evening for a patient, it could be Monday or Tuesday before they have a chance to get through to a nurse or a consultant to ask questions about that. So yeah, I don't think it's a good idea. That's my opinion.
Thank you for your honesty with that. And actually, I'm smiling because I have to say I personally agree with you, just from my own experience and from the experience I hear about from everyone else as well. It's not an easy conversation to have, and a lot of people wouldn't agree with that. But I have to agree with you on that one. you mentioned something about, patients, I guess, wanting visibility. Um, and I chuckled with one of your colleagues, Ashley Grossman, who actually gave me your name and is one of the reasons that I got in touch with you. We talked about this idea that in an MDT, we're a multidisciplinary team meeting, the only person who is not there is the patient. And obviously, it's their healthcare that's being discussed. If if a patient were a fly on the wall in that meeting, what exactly would they be seeing, listening to? What is the insight they might gain into the decision making experience? And then with that, do you think it's something that patients need to be involved with, or do you think actually it's a good thing that maybe the information is then brought to them latterly?
Yeah, it's a really good question. So I think to answer the first part, what would a patient, if they were flying the wall, what would they see? Well, I think most, I suppose I can only speak from my own experience in our MDT, but I think most MDTs operate in this way, that you start with the facts. You start with the facts of the case. So that will be like, the scan results, the biochemistry, the symptoms of the patient, and they will all be reviewed. And then, when all of that is reviewed and we have all of that information and everyone is agreed on that, information, if you like, then if a management decision has to be made, it's at that point then that whoever the person at the MDT who knows the patient best will usually speak up and say, I know Ruth very well. I know she would prefer this option over that option over the other option. She has a pet dog, so she doesn't want to do this, or she doesn't, she's due to go on holidays in a week, and so she won't want to do that. And so at that point, that's normally when the person who knows the patient most will speak up and and discuss the patient's wishes. If nobody at that meeting knows the patient terribly well, which sometimes can be the case, for example, if it's an external referral, then usually that's when we would decide to sit and meet that person to be able to discuss the management options. So the thing that I've learned, and certainly Ashley will have years more experience than me on this, but what I've learned over the last kind of 5 to 6 years is that medicine, and especially medicine when you're dealing with rare disease, is never black and white. And there's never really any one right answer. There's usually a couple of right answers, but there's the best answer or the most correct answer for that individual patient. And yeah, so the final decision will always be best made with the patient. But to answer the second part of your question, whether the patient should be in that actual meeting, I don't think so, because there is a lot of science and fact that does, and kind of medical language that does have to be discussed at an MDT that will be difficult to slow down sufficiently for the patient to be able to properly engage, especially because most MDTs will have to get through, 40 or 50 patients in a sitting. I think and I think it's probably best that a couple of options are agreed upon at an MDT after review of the case, and that they're taken back to the patient for a separate meeting, which is what most MDTs would do.
That's really interesting. Thank you for that insight. It's the first time I've heard about an MDT in that much detail, so I hope it gives to anyone who's listening back, really, really good idea of what goes on. I think I'm actually facilitating a workshop at the moment which encourages patients to become a very active contributor in their own team. And that's not just professionals, that's with, family, friends, patient communities as well. But in terms of, obviously, we're talking about patient-professional relationships here. How do you believe that patients and doctors can kind of collaborate best to achieve those outcomes together? Because what I see a lot of the time is it's kind of one's talking apples and the other's talking pears, or there's kind of this, you mentioned before, like a frustration sometimes on the part of the patient. What do you think, if anything, patients and professionals can do together to make sure that they're moving towards the same goal, and there is clarity, there's visibility, there's understanding, and there's also compassion as well?
Yeah, that's tricky, isn't it? I think, I don't know if I have all the answers to that question, to be honest. I think continuity of care is key, but not always easy to achieve. So we try very hard in our neck clinic for us to see the same patient. So we have 3 consultants in our neck clinic, and we try, that if, say, for example, if I see Joe Bloggs, then at his first visit, then I will continue to try and see Joe Bloggs. That was kind of our mission statement, if you like, when we first set up the neck clinic. That gets trickier as we get busier. But I think continuity of care means that you'll really get to know a patient. You'll really get to know what matters to them. You'll frequently also then, especially in the context of MEN1, get to know other family members, and get to know how the family is dealing with the condition. And I think just knowing your patient very well, and they'll also then know you and know how you tend to run your clinics. When what makes you worried about their care, and all of that. I think I think that's all really positive in terms of patient-doctor relationship. I think doctors continuing to work with patient groups and patient advocacy groups and initiatives like this, I think that's really important as well. Kind of breaking down the barrier in terms of what we do as healthcare professionals, so that's not so alien to patients. Like even for just what we discussed, what is an MDT? We say the word MDT to patients all the time, not realizing that they don't have a clue what it is we do when we sit in an MDT. So I think just those small steps will go a long way to improving, I think, relationships, but also probably improving, the outlooks that patients will have, and how they feel about their condition and how they feel about their care.
Thank you. I agree, actually. I think on everything you've said there, and definitely believe that some sort of breaking down the barrier, I think you called it, and I call it collaboration ultimately, which is that we're all working towards the same goal, just coming at it from sometimes a different perspective, or, there's a different, baggage that we're bringing along. So thank you so much for that. I'm now going to move on to the questions that our membership community have submitted in. These actually, interestingly, go a little bit more into what I could call your other area of expertise, the genetics and the more kind of the scientific, the medical side of things. The first question I've been asked to put forward to you, or to ask you, is